a minute, let me get my slide. Okay.
Yes, I can see it.
So you can see my slides?
Yes, you just need to make it full screen.
Yes. I'll do that right now.
Take your time. And it's 9 p.m. So like you can please start.
And so this is where I was going to start, if that's okay.
Yes, sure. Okay, it's 9 p.m. so we can start. Thank you, Dr. Charles, for joining us today. The floor is yours.
Thank you. And good evening, everyone in Cairo and other parts of Egypt, one of my favorite countries. And I look forward to coming to visit you, hopefully for the EGSSO meeting in November. I have an introductory group of slides I wanted to go over with you as an important announcement about a free service that you can use for consultations and education with experts around the world through our Cancer Expert Now website. As many of you know, we did this before in Egypt. We had a lot of very good responses and participation. The grant has now been renewed. So I wanted to just remind everybody about the availability of this text-based distance learning program. So all of you at any time on your smartphone can put real life or even hypothetical patient cases into our website on your smartphone, and it will start a group thread with up to 3 key opinion leaders who are responding. The average time of response is 2 hours or less, so it's a very rapid response system. You do have the option to submit anonymously. Some people like to do that because they are afraid of being criticized about their patient plans. And it automatically selects the appropriate experts matched to the disease, the stage of disease, and the kind of discipline that you want, medical, surgical, radiation. And we even have a automatic translation. So we can even, you can put this into Arabic, it will be translated into English in America, and then it will come back to you in both Arabic and English as the response. I think many of you already know that Cancer Expert Now has over 700 leading oncology experts from all over the world, primarily in America, but also in Europe. They come from the top academic cancer institutions in the world. They've been leaders in most of our societies that you know, such as ASCO, SSO, ESMO, and so forth. And they're regular contributors to our medical journals. So these are top experts who would respond to your patient circumstance or your question. It's really easy to go on. The registration is shown at the bottom down here. It's my.cancerexpertnow.com/register. And so that we know it came from this kind of presentation, put my name in, although that's not required. You just fill out the simple forms to sign up. And then you can log into this at any time with your password that you select in your email address. And then it will automatically lead you to asking questions, filling out the forms, and then getting the response back. So this just showing you what goes on. You can ask a question. It has your previous questions that you may have asked about breast cancer, lung cancer, or whatever tumor that you're treating. And then you select the diagnosis. These are just drop-down screens that make it very easy to complete. You set your language preference, whether it's Arabic or English or another language. And so this is just the final slide to register for instant access at this my.cancerexpertnow.com/register. and it's free. It's due to a sponsor from Merck Sharp and Dohme, who just gave us a new CME grant for this purpose in the Middle East and in Africa. So Hashim, if it's all right now, I'll just transition from that into my lecture for today that I'm pleased to go over with you. It is a very important subject, that is the new uses of immunotherapy before and after surgery. And as I was talking to Hashim even beforehand, this is revolutionary, and it is very quickly, these treatments are entering into the arena of participating in patients who have surgical diseases, stage 1, stage 2, and stage 3, both as adjuvant therapy after surgery, but increasingly even neoadjuvant immunotherapy, oftentimes in combination with chemotherapy before surgery. The results are remarkable. And because they are so dramatic in terms of pathological complete response, this will, I'm sure, be part of your practice in Egypt where you practice, if not now, in the coming months or the next few years. So it's very important for every surgeon treating cancer of all sites, head and neck, lung, GI, and so forth, to know about this evolving important advance in the management of patients with immunotherapy before and after surgery. And I'll just review some of the principles with you in the next hour. So the first principle that's important to understand is that immunotherapy does not treat the cancer, but treats an abnormal immune response. And in so doing, it enables a personalized immune-based therapy that's unique to each cancer patient, their mutations, their tumor antigens, and the ability of their own immune response to react to their own cancer. We know now that the majority of cancer patients in your practice developed clinical cancer because the cancer induced a state of tolerance. Remember, this is just like the allergist who induces tolerance to grass or dust. So too, the tumor blindfolds the immune system by inducing tolerance so it does not recognize it as being a foreign invader. So if tolerance is broken with these new checkpoint inhibitors, then the immune system, which is already activated, can reject the foreign invader just like it does a transplanted tissue, a virus, a parasite, and other things. Now, and sometimes in breaking tolerance to tumor antigens, one of the side effects may be breaking tolerance to self-antigens. So in monitoring the patients receiving these checkpoint inhibitors, you have to look for any change in their lifestyle, because the checkpoint inhibitors may induce a form of autoimmunity, such as colitis, dermatitis, hepatitis, pneumonitis. The good news is that autoimmune diseases can be treated with steroids in tapering doses. And if the side effects are caught early enough, the patient can then go back on their checkpoint inhibitors. So it's very important in this process, in your patients who are receiving these checkpoint inhibitors, for the patient to understand to call early if there's any changes in their lifestyle, shortness of breath, itching in their skin, fatigue, anything that is not part of their normal lifestyle. They should call your office and get onto steroids before they get into grade 3 or grade 4 toxicity, which is at that point a requirement for stopping the immunotherapy. However, if it's caught early, because the patient gives you a signal that something is happening, you can treat it successfully with steroids in almost all cases, and then go back to the checkpoint inhibitor. So just one slide on the basic mechanisms about how this works. Remember, I told you early on that the revolutionary new information or insight that we've gained is that most cancer patients have an immune response to their cancer, but the cancer has put the blindfolds on through the expression of PD-L1 on their surface, which sends a signal to the activated T cell, I'm not abnormal, I'm a normal cell, don't touch me. Even though it is a cancer, it has fooled the immune system by the expression of these markers such as PD-L1, which binds to a complementary ligand on the lymphocyte called PD-1. And when those two combine, they send a signal to the T cell to leave the cancer alone and allow it to grow and eventually could kill the patient. So the strategy for treatment is giving an anti-PD-1, which blocks that receptor on the tumor cell, or anti-PD-L1, which blocks the receptor on the T cell. Either one of those inhibits that signal of tolerance, and then the other tumor antigens kick in and the T lymphocyte rejects the cancer sometime in a powerful way, as I'll show you shortly. Now we know that there are 7 powerful checkpoint inhibitors that can reverse immune tolerance in humans, and they're in 3 classes: anti-CTLA-4, which is Ipilimumab, which works in the central lymphoid tissue; anti-PD-1, for which there's Nivolumab, Pembrolizumab, Chemoimmuno, and actually a new one that was just approved last week. And then finally, anti-PD-L1, which is Atezolizumab, Nivolumab, and Durvalumab, which works with the same mechanism as a checkpoint inhibitor, just on the side of the lymphocyte in blocking that signaling pathway. So this is a slide that reemphasizes what I told you earlier, that the checkpoint inhibitors don't treat the cancer, because all our cancer treatments are unique to the cancer itself. But in this case, we're treating a dysfunctional immune system, which is common to all cancers. And that's why you see this list of tumors that have been approved in America by their FDA because of proven increases in survival rates or pathological complete response rates in these patients. It's the whole range of tumors. One that was just added last week is head and neck cancers. And you'll see this increasing. So whatever cancer you are treating, it is likely that at some point in time that immunotherapy will be part of your surgical practice. Ones that are still resistant are prostate cancer and pancreatic cancer and sarcomas, for example, but many of these other carcinomas are amazingly responsive. Of course, we have to use biomarkers that help us in selecting the patients. So let me first go over about adjuvant immunotherapy trials that are done after a surgical treatment for stage 2 or stage 3 disease. And so far, these 4 tumor types have effective demonstration in randomized clinical trials for melanoma, renal cell carcinoma, urothelial tumor, and lung cancer. And just to show the examples in melanoma, which I know you don't have much of in Egypt, but these were the first trials done to demonstrate in adjuvant therapy a significant improvement in survival rate in patients who have received adjuvant checkpoint inhibitors with either Nivolumab or Pembrolizumab. And then this is for Dr. Zugul in urology, that adjuvant Pembro is used after nephrectomy. Again, you can see a highly significant p-value and a 32% reduction in disease-free survival compared to placebo as monotherapy after nephrectomy and renal cell carcinoma. And then in urothelial tumors, yet again, this is another recent publication just less than a year ago, showing both disease-free and overall survival of patients with urothelial tumors who are receiving nivolumab versus a placebo. And one of the teaching points here is that I'll show you in other studies in patients who have a higher expression of PD-L1 on their surface. And this is also used as CPS scores. The higher the PD-L1 or the CPS score, the greater the immune response, the more robust and complete the response is. And that translates into higher survival rates, as shown in the right-hand survival, where the hazard ratio here shows a reduction in relapse-free survival of 45% with a highly significant p-value. I want you also to notice that these curves plateau after 30 months. That is, patients who are free of their disease, which in the nivolumab treated arm was about almost 60%, no patient relapse after that. They are cured. We're even finding this in stage 4 disease in patients who get a complete response. They do not relapse because their immune system stays active. And in the few that do relapse later on, you could go right back to the checkpoint inhibitor and get yet another response. And so this is in the non-small cell lung cancer with durvalumab, again showing a highly significant reduction in disease-free survival, distant disease-free survival with durvalumab compared to placebo. Look at the median tumor disease-free survival. It's 28 months versus 16 months, a highly significant difference. And then this is another study in non-small cell lung cancer with Atezolizumab and anti-PD-L1, showing that in adjuvant therapy, who have a PD-L1 score of more than 1%, that they do better than best supportive care in patients with stage 1, stage 2, and even in stage 3 cancer. These are highly significant difference. And again, these are recent publications in the last year, and you will see more of these each month as the current trials are being reported. So I want to move into neoadjuvant immunotherapy because there is a significant advantage of giving these checkpoint inhibitors even before surgery and then determining whether the immune response was able to completely destroy the tumor. And if not, then to use a second strategy after surgery. So neoadjuvant therapy allows us to determine whether these systemic agents really work in the tumor you know about, and if not, to switch treatments after surgery. And this has been successfully used and approved in America for these type of tumors that I'll just review some of their data. But first, let me just review the advantages of neoadjuvant therapy in your patients, especially those with stage 2 and stage 3 cancers of various types. First and most important, in the majority of patients, there is a significant reduction. And as I'll show you, what's even amazing is pathological complete responses in many of these patients. But even if it has a partial response, it downstages the tumor, increases the ease of the surgical resection. And as I'll show you in one slide near the end, it even converts inoperable tumors into operable tumors. And then now we're increasingly using pathological response as a surrogate endpoint for long-term benefit. This allows us to get answers about efficacy in various tumors and stages of disease early on by using pathological complete response, which we get right after surgery, instead of waiting for 2-year or 5-year survival rates some years later. And then we could also test novel combination strategies and even investigational drugs because we have access to the surgical samples for correlative analysis. In other words, we want to know if there's residual tumor did the molecular profile change in those cells that are resistant to the initial treatment? And based upon that information, we could develop strategies for giving different types of treatment after surgery. So the other reason for giving immunotherapy before surgery is the response rates are even better than they are in patients with a more advanced disease, which is immunosuppressive, since neoadjuvant patients are less likely to have been heavily pretreated with chemotherapy or less immunosuppressors. And then we increasingly have molecular markers to select patients and evaluate end results. So these are all the reasons. There are quite a number of publications. I selected these three if you want very good review articles. I like the title on this from Lex Egermont in Europe to say the future is now. And I think, as I've told you, that as these agents are increasingly available and affordable in Egypt, this is going to be something that will be part of your practice. Now, here's part of the rationale about why neoadjuvant therapy probably works better than in any other setting, because you're trying to activate the immune system. And at that time, there are more tumor cells there that could act as a vaccine to immunize and to boost the immunity with activated T cells with these tumors in place. The contrast is in patients who have had adjuvant therapy, their tumors removed, they may only have a few thousand or a few million cells, so it's not going to be as immunogenic as it would be in neoadjuvant therapy, where you may have millions or billions of cells that could actively stimulate the immune response and boost it so that the immune system will give a more robust and complete response when the tumor is in place. And there's some hints of this. This is not a randomized study, but it's one of these studies at the same institution here at the University of Pennsylvania, which compared the results in melanoma with survival rates of patients getting the same drugs after treatment versus before treatment. And they found consistently that neoadjuvant systemic therapy for stage 3 melanoma was associated with improved 3-year distant disease-free survival compared to adjuvant systemic therapy in the same stage of patients and with the same drugs. And it allows for an early assessment of pathological complete response. So I want to point out to this yellow line, these in the yellow are patients who had a partial or complete response to the checkpoint inhibitor, and you can see they did very well, whereas the patients who did not have a response did very poorly. So now we could sort out those patients who are going to do well and treat them less aggressively, whereas those who are not responding, which you documented surgery, we have to go into other treatment strategies to improve their survival rates. And I'll show you an example of that later on. Now, just to show you the power of the immune system once the blindfolds it off and its capability of rejecting cancer is unleashed. It's not something I would necessarily recommend, but it makes a nice point. This was at the Mayo Clinic where they gave a single dose of a checkpoint inhibitor in patients with resectable melanoma, and then did remove the tumor and looked at the viability. And what was remarkable is that 30% of patients after a single dose had a major response. That is, 90% of the tumor was destroyed. And in 20% of those patients, there was no viable tumor left after a single dose of a checkpoint inhibitor. So I want to just go over, because historically, we learned the most about immunotherapy with these checkpoint inhibitors in melanoma. Again, acknowledging this is not a tumor type you see in Cairo or in Egypt, but the principles of what we learned in melanoma in manipulating the immune response work equally well in other tumor types, as I'll show you later on. So this is just an example of one study done. It's a global study looking at different doses and dose schedules of using a combination of Nivolumab and Ipilimumab together in melanoma. Now, historically, I've been doing melanoma trials for 40 years. If we had a response of 10% of total response, that would be fortunate. The best we've ever done with interferon interleukins is 20%. But look at here, with these checkpoint inhibitors, patients with these different dose schedules, same drugs, different dose schedules, who had a pathological response, 80%, 70%, 77%, 65%. We have never, ever before seen these kind of major responses in melanoma with these types of responses. Even 57% of patients with this dose schedule B, which they're now using as standard of care, 57% of the patients had no viable tumor left after the 4 months of neoadjuvant therapy. And then the dose responses on immune-related adverse events, you can see here. But the point is here in group B, which gave the best pathological complete response, also had the lowest level of adverse events. So this is now the schedule that is used. The other teaching point in here is looking at patients who had a response versus those who had no response. So this gives us a new prognostic metric of looking at the response to the immunotherapy as a predictor of survival rates. And as you could see in these 64 patients who responded, only one person died, and that was not related to their melanoma. So every one of these patients are living in an updated paper I don't have here at 36 months. So this is a very important part of the staging of surgery, of looking at the degree of response with these checkpoint inhibitors, and then from that, knowing the prognosis and defining other forms of therapy. So this is another teaching point I wanted to go over with you about the difference, again in melanoma, and we're going to find this in other tumor types, between targeted therapy against the BRAF mutation versus immunotherapy. And the key point in here, and it actually in a new study that was just reported last week, that immunotherapy gives a better and more durable survival rate than targeted therapy. So even in the BRAF mutant patients, instead of going to targeted therapy with the BRAF/MEK inhibitors, that immunotherapy with the combination of checkpoint inhibitors, CTLA-4 and anti-PD-1, has better survival rates. And then if they relapse, of getting the targeted therapy second versus the reverse, where they start out with targeted therapy and come back with checkpoint inhibitors. So the key point here is in all melanoma patients, even those with BRAF mutation, checkpoint inhibitors trumps targeted therapy. All right, and this is my last slide on actually one more slide on melanoma. This is yet another injectable neoadjuvant treatment with TVEC plus surgery versus surgery alone. And this was again reported recently. And as you can see, those patients who got the neoadjuvant immunotherapy with TVEC did better than patients who had a placebo. And then finally, my last slide on melanoma. Again, the principles are what's important. These are patients who had inoperable advanced cancer and who had immunotherapy, and because of a good response, were converted to operable patients. So their conclusion in this paper, again published last year in the Annals of Surgical Oncology, is salvage metastasectomy was associated with durable survival and disease control, particularly if you could resect the metastasis to no evidence of disease with preoperative immunotherapy. And this just shows you that what's important is the blue line up here. These are all patients with advanced stage 4 inoperable cancers that were converted to operable. And those patients who were converted to no evidence of disease, you can see, did very well out to 5 years. And even those who had a significant partial response, that is less than 10% viable tumors, did very well compared to those patients who did not respond. The other teaching point here is those patients who got preoperative therapy with immunotherapy did significantly better than those who got preoperative or neoadjuvant targeted therapy, again reinforcing the principle I showed you in the previous slide. So let me move on to some other tumor types that are more relevant to your practice. And here's an example in neoadjuvant PD-L1, one of the first studies in 2018, using Nivolumab. And you can notice that there was a major pathological response in 45% of the resected tumors. Now, there's one teaching point here that I want to show you. It is clear that as the PD-L1 expression on the tumor, a biomarker, as that increases, that the response rate and the durability of the response increases as well. But this tumor marker, this biomarker, is not perfect because you can see there are a few patients who are PD-L1 negative who still had a response. So at least for right now, until we sort this out better with other biomarkers, then we don't exclude PD-L1 negative patients from the immunotherapy, although most of the approved indications require at least 1%, and in some cases 10%. So here's another important teaching point for all of us as surgeons. So, and that is that radiological assessment of these tumors to determine response is unreliable. And that is because the mass we're seeing is oftentimes replaced by scar tissue and inflammation. The mass doesn't shrink, but there's no viable tumor in it, but you can't tell that on any radiological study, including PET scans. So it is required for surgeons to take the tumor out so the pathologist can determine whether there's viable tumor. So here's a good example of a patient who had a fairly large non-small cell lung cancer. And at week 4, before surgery, there was what was viewed as a partial response. But when this tumor was removed, there was no viable tumor. This was a pathological complete response, but a radiologic only partial response. And here's just another example in that same article. Again, a fairly large tumor, which did not appear to respond at all. But when it was removed, the mass that they're seeing on X-ray was all scar tissue and inflammation. There was no viable tumor. So folks, even though this is a revolutionary advance, remind your medical oncology colleagues that surgeons still have a role for staging these cancers. That's very important and will increasingly allow us to operate on patients we usually didn't do because we need the staging information on the response to the checkpoint inhibitors. All right, so here is one other trial, again with a combination of chemotherapy and immunotherapy, that is Nivolumab and Taxol duet before surgery for 3 cycles. And as you can see in this patients that they had a, wait a minute, I have to move, a complete response in 71% of patients. And these patients that were all high-risk stage 3A patients, that the 2-year survival rate was 77% in this non-randomized study. Now, here is yet another one in looking at a combination of Nivo and IPI, that is combination checkpoint inhibitors with different mechanisms of action compared to Nivolumab alone. And as you can see in these diagrams, that the addition of the combination of ipilimumab and nivolumab produced more pathological partial and complete responses compared to nivolumab alone. So again, the clinical trials have to sort out whether to use checkpoint inhibitors as monotherapy, whether to combine them with chemotherapy, or to use combinations of checkpoint inhibitors from these various studies. But this is still being sorted out. Now, here is another study, again with neoadjuvant chemotherapy and immunotherapy, again using Taxols and durvalumab, another checkpoint inhibitor. And as you can see, there was a major pathological response in 62% of patients, nodal downstaging in 67% of the patients, including 47% of the lymph nodes being downstage to no viable tumor, and an 82% two-year survival rate in these patients, yet again showing the value of neoadjuvant therapy. So then I wanted to also show a third study. This is one of the more recent ones on using, again, a combination of nivolumab and platelet chemotherapy as neoadjuvant therapy. This is the combination of Nivo plus chemo, chemo alone, or Nivo and IPI alone. And then the patients had optional chemotherapy or radiation therapy after surgery. Sorry, I'm going the wrong way. So here is the endpoints to show you in the patients of the pathological complete response in these patients. And you can see the combination with Nivo and chemo was 24% versus chemotherapy. Only 2% had a complete response. And then again, in the intention to treat arm, Nivo plus chemo, 36.9% response versus 9%. So again, a highly significant difference showing in this circumstance the addition of checkpoint inhibitors to chemotherapy with Taxol Taxol and platinum was associated with a significant improvement. And then here's a final study that I want to show you with yet another new principle. And these are patients, this was just published last year in the New England Journal of Medicine, a major study in patients with esophageal or gastroesophageal junction cancers, all of whom received neoadjuvant therapy with combinations of nivolumab and chemotherapy. And then after their surgery, they were randomly assigned to nivolumab for another year versus a placebo. And so this again shows you the advantage of giving additional treatment after surgery with nivolumab monotherapy, again showing a highly significant improvement in disease-free survival in the left-hand curve. And the right-hand curve shows that regardless of whether the tumor type with squamous cell or adenocarcinoma, the histological type, both types did better than the placebo receiving adjuvant nivolumab after neoadjuvant immunochemotherapy. So this is going to set a new standard of treatment for patients with esophageal and gastroesophageal junction tumors. Now, I told you that PD-L1 is not a great predictor of response. It correlates with higher PD-L1 or CPS score with more durable and frequent responses, but some patients who are negative still respond, but not as frequently and they're not as durable. There is, however, one biomarker that works very well, and that is a standard immunohistochemical test done routinely in your pathology labs of looking at mismatch repair deficiency by immunohistochemistry or it's also called microsatellite instability high versus low. And these are standard immunohistochemical tests that can be done in your pathology lab. And the response in these patients that I'll show you in the next slide, this one in colon cancer, was dramatic. So in patients who received neoadjuvant treatment with a single dose of ipilimumab and 2 doses of nivolumab, had a 100% pathological response in those patients who had a mismatch repair deficiency gene. But in those who did not, it was only 27%. 100% pathological complete response, or a major response, and most of these were complete responses. So for the first time in America, our FDA approved the use of these checkpoint inhibitors for any patient with any type of cancer that expresses either the mismatch repair deficiency mutation or the microsatellite instability high test, regardless of their tumor type. Now, I have to put this in perspective. This is only 5 to 6% of patients with colon cancer, but interestingly, patients with gastric cancer, with sarcomas, with some of the pediatric tumors, and with breast cancer also get a very high pathological complete response in those infrequent patients who have expressed this MMR deficiency or MSI high. So this is a forerunner, I think, of predicting patients that we could get major responses. And it just to show you, to reinforce the teaching points I made earlier in this study with a they had 121 patients that they treated. And the key point of this article is a pathological complete response was noted in the resected specimen of 13 patients, despite the presence of residual tumor on preoperative imaging in 12 of the 13 patients. So the key point here again is that radiological assessment of these tumors of all types is not reliable, and that surgeons need to take out the tumor or the tumor bed and give it to the pathologist to determine the level of pathological complete response. So this was the example in some of these patients. As you can see, this is a pre-treatment of a metastatic colorectal cancer to the liver, a large one. And after 12 months of treatment, it looks like there's just a partial response. But finally, somebody convinced the surgeon and the medical oncologist to take the tumor out and look at, there was no viable tumor in this mass that was seen here on X-ray with the red arrow. All right, and just to show you yet again, another teaching point here again in resectable Merkel cell carcinoma, which is really like a sarcoma of the skin. You do see this in Egypt. It's uncommon, but there's another teaching principle here showing, again, the prognostic value of knowing whether there's a pathological complete response or not in patients who have been treated with neoadjuvant nivolumab in this circumstance. And as you can see, this and in other studies, a highly significant difference in those patients who achieve a PCR versus those that do not. And then finally, I wanted to finish off with head and neck cancer. Again, these are HPV positive and negative squamous cell cancers in patients who receive neoadjuvant nivolumab. And you can see in the HPV positive patients, it induced a pathological regression in these surgical patients in 23%, a very low pathological regression in the HPV negative patients. Again, showing that the HPV presence may indicate a better response in these patients with squamous cell carcinoma of the head and neck. And then again, looking at the responses in these HPV positive patients, the clinical to pathological downstaging occurred in 90% of the patients. So you can imagine in some of these more advanced cancers, if you get a reduction, even to a pathological complete response, it facilitates the operation in a patient who otherwise may not be operable. And then finally, there's evidence in a randomized trial for breast cancer. I'll just finish at the end because I know many of you don't treat breast cancer. I do. And again, you can see here in this randomized study of patients getting pembrolizumab as neoadjuvant therapy for stage 3 cancers versus a control, that the pathological complete response was tripled in the TNBC, the triple negative breast cancer patients, but was also increased in the HER2 negative patients and even HR positive patients. So this is my final slides just to summarize about the key strategies. First, these immunotherapy with checkpoint inhibitors doesn't treat the cancer. It treats a dysfunctional or abnormal immune response. So remember, if we're doing something to treat the cancer directly with chemotherapy, targeted therapy, or radiation therapy, in patients who are also receiving the checkpoint inhibitors, the tumor breaks down and actually boosts the immune system. So it acts as an internal vaccine, and that's why you're going to see increasingly combinations of treatment that attack the cancer and break it down and release tumor antigens, and checkpoint inhibitors at the same time, which then activate the immune system. In the presence of continuing exposure to tumor antigens, actually get a very robust immune response. So remember, the checkpoint inhibitors work by a mechanism of breaking immune tolerance to tumor immunity, but the side effects, they can also break tolerance to some self-antigens, resulting in autoimmunity. Remember, the autoimmunity can be treated successfully in almost all patients with tapering steroids, and it's important for the patient to give a signal that there's some changes so that you can treat them with steroids early. The immunological rejection process of a cancer results in inflammation that can take weeks or months to fully complete measurable changes in size. So the only reliable endpoint for assessing responses to neoadjuvant immunotherapy is the histological exam after the surgeon takes out the tumor or the tumor bed. The other point that makes this very remarkable or dramatic is the remissions are durable for months or even years in more than 80% of the responders, including those even with minor responses or stable disease. So for us as surgeons, surgical removal of the tumors treated by checkpoint inhibitors will be important, and I think increasingly used in your practice, as these drugs, which I understand are expensive and hard to come by right now, but that will change, to determine the pathological response to the treatment, to convert inoperable patients to operable situations, or to allow for reduced surgery. And there are some exceptions to that, as I told you, like pancreas cancer, sarcomas, and prostate cancer, but there are 17 different types of cancer where there is major responses. And then importantly, to select different adjuvant systemic treatments when there is residual disease after neoadjuvant therapy, doing molecular markers of the residual tumor, and then determining whether further continuation of the immunotherapy or switching to other forms of treatment is important based upon a molecular and genetic analysis of the residual tumor that was resistant to the neoadjuvant therapy. So there's a lot of issues that are going to be reported, many of them this year. I think you'll hear a lot with the ASCO meeting that comes up in June. There'll be many new presentations of significant advances, but we're looking now at combinations of checkpoint inhibitors plus chemotherapy and targeted therapy, checkpoint inhibitors plus radiation therapy. the selection of different adjuvant systemic agents with patients with residual disease after receiving neoadjuvant therapy, and increasingly will be better at the use of biomarkers to select patients who have a greater probability of responding and to evaluate results. And then finally, defining the optimal duration of immunotherapy treatment is something that we don't yet know. Generally, and it depends upon the trial, which depends upon the medical oncologist, the neoadjuvant therapy is given for 4 to 12 months. I'm a fan of doing it only for 4 months and not waiting for a year, for which resistant mutations might break out during this time. So we need to know, and that's where you need to be communicating regularly and insisting that the patient go to surgery at an appropriate early time. We also don't know in patients getting adjuvant therapy. Many of these trials have been 2 years of treatment. Now we're increasingly going to 1 year, but these are arbitrary durations. We don't know yet how long is necessary for our patients to receive adjuvant therapy after their surgery. So that's the end of my talk. And I really I always appreciate the opportunity of coming before my friends. And hopefully we'll have new information we can talk about in November when you have your EGSSO meeting, I think in Cairo. So thank you so much for the privilege of coming before you again. And I hope this information is helpful.
Thank you, Dr. Balch. It was a very informative talk. We can start by taking questions from the audience. Please, if you have a question, raise your hand. Any questions from the audience? Dr. Walid.
Hello, thanks a lot, Dr. Balch, for your presentation. I would like to know your opinion. Could neoadjuvant immunotherapy have a role in a locally advanced renal cell carcinoma?
There are trials going on in renal cell carcinoma. As you know, that the adjuvant therapy was highly successful. And so there are trials going on now with neoadjuvant therapy that have not yet been reported. But I think you could predict pretty accurately that if it works after surgery, it will work even better for a period of time before surgery. But the results are not out yet, so I can't tell you except that these are ongoing clinical trials.
Okay. I have a question regarding the trial where they were giving adjuvant immunotherapy for gastroesophageal junction tumors.
Yes.
You mentioned that they were giving neoadjuvantly, they were giving immunotherapy and chemotherapy, and then why not give in the adjuvant setup also chemotherapy and immunotherapy, and not only immunotherapy alone?
You'll have to go back to that paper in the New England Journal of Medicine. I think they got neoadjuvant chemo and radiation therapy, the standard treatment before surgery. And regardless of the response, they all got adjuvant nivolumab compared to a placebo. So the immunotherapy was given post-op, not as neoadjuvant therapy. I got confused because there are some other trials going on right now of giving immunotherapy and chemotherapy for esophageal and GE tumors as neoadjuvant combination, but those have not yet. There's been non-randomized studies published which show a high response rate, but the randomized trials have not yet been reported. And certainly this is another example of downstaging these tumors, sometimes which can be very large, and facilitating an operation that otherwise might be associated with a lot of morbidity. And in addition, it gives some time for the patient to have nutritional repletion while they're getting their neoadjuvant therapy, so they're better able to tolerate the surgery and have less complications such as wound complications and infections.
Okay. Dr. Gamal Amira.
Clarification.
Dr. Gamal.
Yes. Good evening, Dr. Balch. How are you?
I'm doing great.
Hello?
Thank you. It's nice to be with you late in the evening. Now it's 10 o'clock. So you are all dedicated surgeons.
Thanks very much. My question is that when the cases have complete pathological response after surgery for checkpoint inhibitor. How to avoid surgery in these cases which have responded completely? Is there a way to mark or to avoid surgery?
I'm so glad you asked that question, because that is a typical question your medical oncologist would tell you. We could skip surgery. And the answer is no. It's important to stage whether or not there's a pathological complete response or not, because that may dictate not only prognosis, but a change in treatment strategy after surgery. And my whole key point here, because I know our medical oncologists in the United States, because remember I was CEO of when I worked, they underestimate the treatment value and safety of surgery, and they overestimate the morbidity. And many of them will go to great lengths to avoid an operation. And I don't think this advance substitutes for surgery, but makes surgery staging even more important. And in patients with inoperable or borderline operable disease, can convert them into a safer operation and a longer survival. So I'm glad you asked the question, because my whole point in this, there are many, many articles publishing to show that in breast cancer, GI, and all these other tumor types, lung cancer, that radiological assessment is not reliable for determining the degree of response. And remember that even more than 10% viable tumors is associated with a much lower survival. These are patients that need to be separated for more aggressive treatment. But conversely, those patients who have a complete or near complete response might not need any treatment after surgery, or might need something less aggressive in their treatment, because they will do very well. And the key point here is that the pathological complete response is a surrogate, an accurate surrogate of survival. So if they have a PCR, the curability is more than 80 to 85% in those patients with the results so far. Okay. That's impressive. And that's why I say, this is going to find its way into your surgical practice.
But don't you think, like, maybe in the future, when this treatment is better established, may we eventually reach something like the watch and wait policy in rectal cancer, maybe in the future?
Well, the surgeon in me says, why wait for a relapse when it might compromise the patient's survival? Because we could do an operation safely and determine the degree of response. And equally important, if there's not a complete response, we need to know the molecular profile of the resistant cells, because that will help us in changing new strategies with targeted therapy or other forms of treatment. So I actually think that the role of the surgeon is going to increase, not decrease, because of the value of the pathological assessment of the tumor after neoadjuvant treatment.
Of course.
And that's why we have to present it to our medical oncology colleagues. Surgery is a local treatment. They'll say, well, we don't need your local treatment anymore, but you need it for staging and for local disease control, even if we're not per se increasing survival rates with surgery alone.
Okay, Dr. Gamal, you have another question?
Yes, please. Another question. We used to treat cases with of breast cancer and esophageal cancer with neoadjuvant chemotherapy, and we used to have good results. Is there a randomized trial to compare neoadjuvant chemo versus check inhibitors or immunotherapy in both these cancer, gastroesophageal and breast cancer?
They have not been reported yet. The only randomized trial, which is not a traditional randomization, is the I-SPY trial, in which patients were randomized to different dose schedules of the drug to predict their response in a randomized trial, because the purpose of doing that is to avoid a negative expensive randomized trial. So that's the only information that we have today. But even that was dramatic. You triple the pathological responses in the triple negative breast cancer. But your question is a good one, but it is one of the results that are going on now. I would point out that in the world, there are over 1,200 clinical trials going on right now in immunotherapy, whether advanced disease or surgical patients. So there's going to be an amazing amount of new information that's going to be reported, and it will be important for the EGSSO and all of you to keep up with these advances as they impact on your surgical patient.
Thanks very much. Thanks.
Dr. Yasser?
Good evening, Dr. Balch. Thank you for your nice presentation. I have just a couple of questions, if you don't mind. Do you have an explanation for those patients who were treated with immunotherapy and were PD-L1 positive, that they did not achieve any response? Yani, for example, for the esophageal cancer, we can get, when introducing immunotherapy with chemotherapy, we can get a response rate in about 37% or something like that. What about the other percentage of patients, the other 60%? Do you have an explanation why they didn't achieve a response on immunotherapy?
Well,
And also, the second question,
so I don't get lost. And I'm glad you asked that question. In my enthusiasm about immunotherapy, you do notice that not everybody responded. There's still more work to do. There are some patients who are refractory to immunotherapy with these checkpoint inhibitors, which means that the tumor escaped with a different mechanism than what we're seeing. The other part now is we're coming up with, there are at least 10 new forms of immune stimulants and checkpoint inhibitors that work with different mechanisms of action that will be reporting. Just, melanoma has been leading the field because we started there. And just last week, a new LAG-3 checkpoint inhibitor plus nivolumab was found to be better than nivolumab. Again, the combination had different mechanisms of action and had a significant improvement in survival in patients with advanced melanoma. So your point is very well taken that we can't tell our patients that all of them are going to get a successful approach, and there's still more work to do in some of these. And I think the success is going to be on having molecular markers and biomarkers that help us select from among this menu of systemic treatments to treat our patients up front. But since we don't have good prediction, it's important to give these treatments up front with the tumor we could see, and then find out how well it worked by taking it out after a period of 3 to 4 months, not a year, and then determining the new genetic and molecular profile. This is going to be the future of how many, if not most, cancers will be treated. Okay, your second question.
Dr. Yasser, your second question, yes?
yes, my second question about Nivolumab. You think you can see that there is some patients who are not expressing of PD-L1, they get some response. Also, I wish to know if you have an explanation for this phenomenon.
No, other than they may still be tolerant, but they are tolerant in a different mechanism. I mean, these tumors, if they're going to survive, find escapes from the normal mechanisms that are supposed to reject them. So I think we're finding, just like I told you, we have a new pathway of checkpoint inhibitors, which we didn't know about, this LAG-3, totally different signaling pathway. And as we learn about these different signaling pathways, at least as it relates to immune stimulation, then I think we'll be able to use combinations and get better responses. So this is the first entry of immunotherapy and biomarkers, but as people now are finding that there's a whole array of signaling pathways that vary from person to person and from types of cancer to different types of cancer. So we still have a lot of work to do, but we're off to a great start with new tools that we haven't had before. But I think your point that you're asking is there's still much work to be done. And my encouragement for all of you is wherever possible to get involved in some of these global trials and help us answer these questions as quickly as possible so we can get rapid accrual, get the answers, and then move on to the next question. Instead of doing these trials that take 3 years, 5 years or longer to complete.
Okay, thank you. Do you have any other questions? Okay, I think that was the final question. So thank you, Dr. Charles. Thank you. Thank you, Dr. Charles. It was a very nice presentation. If you have the time, we would certainly like to schedule another webinar for the chemotherapy talk.
Okay. You know, I'd always be glad to come before you and talk about cancer treatments.
Thank you, Dr. Charles. And looking forward to seeing you in Egypt again.
And good health to everyone there.
Thank you.
Take care.
Okay, bye-bye. And good night, everyone. Bye-bye.